Stop being afraid of opiates. If it's Monday, it's magic. Hey everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester here talking about new stuff in EMS and paramedicine. And today we are talking about this journal article that came out from the Journal of Emergency Medicine. This is the frequency. Hang on. I got this, honest. All right. This is the frequency of persistent opioid use 6 months after exposure to IV opioids in the emergency department. This is a prospective cohort study. This is from Eddie Irizarry et al., and this is out of our friends at the Boogie Down Bronx. This has come out of Einstein and Montefiore. What's up, all of our friends in New York? So this study was looking at intravenous opioids, and essentially the question that they asked in this study was, do people that receive opioids in the ER tend to take opiates again? This study was done between March and August of 2022. They screened 1,555 patients and enrolled 550. We'll talk about that exclusion in a minute. Here we see the patients screened. They got rid of about 2/3 of the patients actually in the cohort during enrollment. And what they found here is fewer than 1% of opioid naive patients discharged from the ER got more opiates within 6 months. Here's some of the baseline variables. So here we have, the actual mean 46, more women than men, which I thought was interesting. And then they also show the opioids that the patients were given at discharge, which is usually APAP and oxycodone, APAP and codeine, APAP and hydrocodone, or tramadol. So what they were looking at in this study were patients who got opiates, and usually they received morphine. But really what they were looking at was recidivism after they received this treatment. So Dan, we've heard for years that we don't want to give patients who have never received opiates before opiates because they might be addicted to them.
Yeah, this has been a thing that gets bounced around a lot. And, with EMS and our first line pain meds are usually an opioid pain reliever, fentanyl, whatever, what have you. Some of you have Toradol or some NSAIDs or something like that. Some of you have IV Tylenol. That's great. But we're looking specifically at opioids. Would they develop some kind of addictive personality or use disorder coming out of just getting it for an emergent condition? This study and, urban center in New York City sees a lot of patients. I'm interested to see how they disqualified 2/3 of the people initially in the study, and we'll get into that. But it's to show that in this study, have too much to worry about from giving isolated doses of single course of an opioid pain reliever for someone with a condition.
And I think that's right. Now, what they were looking at here was, again, patients who were naive to opiates when they came into the ER and were then discharged. So this is a very interesting model in the way that they did this study. So part of the exclusion was they had people that had previously used opiates before they came into the ER within 6 months. So the 2/3 exclusion, I think really very importantly, were people that already had a use disorder or had used before they were enrolled into the study. So when they were actually recruiting people, they went through to see, is there opiate use already? And if there is, that's when they were excluded from the study. And they were excluded from the study in that setting because they already used opiates. And just to bring up the screen again real quick, because something I thought was fascinating in this study that probably we see a lot. Here we see 40% of patients that were discharged because of abdominal complaints. And one of the things that you hear a lot in the use of opiates is that we shouldn't use opiates for abdominal pain, because if we use opiates for abdominal pain, it's going to slow the gastric motility, it's going to cause further problems down the line. Now, obviously, this doesn't show that to be true. And it's certainly something that we probably run into the field. Now, I don't know that I'm going to run and give fentanyl to someone who's got abdominal pain or maybe a urogenital injury would get fentanyl or morphine. And then again here, about 15% MSK, and then 11% multiple diagnosis, 6% for infection, which I thought was kind of fun. So we have these patients who are getting opiates without having previously taken. So the idea was that their first introduction to opiates was in the ER. What I like about this is they did exclude patients who already were using opioids, because that's a different study cohort, right? In that, to get that group, you would have to say, all right, we want to see if they prolong their opiate use. This group were people who are naive to opiates before they come into the ER. They come into the ER and get the opiates the first time and are sent home with an opiate prescription. So what they were looking at was to see, does that particular setting increase the odds of opiate abuse and readmission? And it turns out what they found was there was only one patient in this entire cohort who actually came back for more opiates. So it seems, at least among this population in the Bronx, that these patients who are opiate naive, when they get opiates in the ER, they don't generally tend to come back for more opiates.
It's a very interesting study because it kind of flies in the face of what we've been told. I think, it's always good to have stewardship of these meds, and especially for those acute turning into chronic issues. I think that's where you get your real red flags, right? But we don't see that too much in EMS. What we see is musculoskeletal injuries, traumatic injuries, the abdominal complaint, not the boo-boo tummy. I don't feel good, but the real people potentially are surgical, potentially acute abdomens. That's really what we're giving it for. And, there's always that worry that you're going to start somebody down a road that they're not going to be able to navigate. And I think this study pretty conclusively showed that that's not true. Even when they got take-home opioids, which is becoming more and more rare, points to these people had legitimate pain issues that had to be addressed. The results here are pretty promising, and we shouldn't go away and throw away our fentanyl and morphine just yet. Well, maybe morphine. But definitely the opioid pain relievers are something that should be in our armamentarium and something that we should continue to use cautiously, always with an eye towards protecting people from use disorder. But that person who fell and broke their arm, broke their leg, took a tumble down the stairs, okay. I think we're in good shape with this. It's something to go ahead and give them that medication, obtain that pain relief. The risks of putting them down a bad road is really kind of minimal.
And in this study, a really cool thing that they did was they actually brought up patients. They gave a couple examples of patients here too. So here we've got a patient who received 4 milligrams of morphine for chronic knee pain. And here they list the concerns for opiate use disorder. So continued intermittent pain, knee and back pain. Here we've got pain from malignancy, MSK pains, all this stuff. Again, patient ended the use of the opiates 6 weeks after an orthopedic surgery. And then we have down here, this is a great graph here, the number of opioid prescriptions filled by each study participant. Now, again, we had a little over 500 patients in this actual group here. So we have the number filled by each study participant. A bunch of them, 388, did not fill a prescription at all once they were sent out. 86 filled 1, 22, and then we have a couple people, then you see this one right down here. And then number of prescriptions filled, excluding opioid prescribed to the ED, same thing. We actually have more people not filling their prescription once they're actually discharged. So the conclusion here, 506 opiate naive ED patients administered IV opiates for acute severe pain. Only one used opiates persistently after 6 months. Our findings suggest that the use of IV opioids for acute pain in the ED is extremely unlikely to lead to opiate use disorder. Now, the important thing to mention in that is that the word that's used in there a lot is acute. And what that is saying is that if someone has acute back pain, acute knee pain, acute whatever, and they go into the ER and they're given morphine, fentanyl, whatever, for their pain, that one instance is not likely for them to continue to use opiates. And maybe they just use whatever, NSAID painkiller for whatever pain they have. That being said, there are data that suggests that patients who are given large take-home prescriptions, now this is kind of jumping in the face of what happened 10, 15 years ago, when OxyContin was really popular. So it used to be that patients were getting these huge prescriptions, right? They were being sent home with a 90-day supply of OxyContin. And that's where that addiction kind of started, right? Where you're home, you have this endless supply. What's changed in a lot of send home prescription modeling now is that doctors will give a 5-day prescription or a 3-day prescription, right? Where, I'm going to give you OxyContin, but I'm only going to give it to you for a couple of days to reduce that addiction risk. So there's one way to look at it, which is the changing of the ways that we've given opiates has led to, fewer addictions after care. But there's also a way to look at it that maybe this was just a problem that was a little bit blown out of proportion. Because I think a lot of times in medicine, especially in emergency medicine, we tend to view things as binaries, right? Where this is either going to be not a problem at all, or it's going to be the biggest problem ever. And we try to stop the biggest problem ever. And I feel like sometimes that leads to overcorrection.
Yeah, if all you have is a hammer, everything looks like a nail, right? If you make people, obviously you're going to take pain away, you're going to make people feel better by giving them the opioids and refilling those meds. But we know what that leads to down the road, and I think the data is pretty good on that. Actually, we need to be cautious in the chronic pain patient. Not necessarily, and I'm not even counting the sickle cell population because that's a whole nother curveball. So
Yeah, that's a whole other conversation.
Don't even put them into this. I'm talking about musculoskeletal, abdominal type issues, things that we treat for pain that these things are not an issue as long as we practice good stewardship. And in EMS, that dose, again, we're giving 1, maybe 2 doses of this during transport. Very, very unlikely we're going to cause problems. I noticed now in most of the places that I transport to, after a dose of opioids or, the follow-on of, the second dose of opioids, I'm seeing a lot of IV Tylenol. I'm seeing a lot of I'm seeing a lot of multimodal pain stuff, not necessarily just kept redosing with the opioids. So I think this was potentially a problem that was created by modern medicine. The idea of relieving pain, and now that we have other agents to do this, I think this is a good study that says we don't have to be scared of our opioids, and our patients don't have to be scared of our opioids. You get a lot of patients that will tell you, "Oh, I'm scared. I don't want fentanyl. That's what killed Michael Jackson, or that's what killed this guy, or whatever." And that's not true either. So it's a good opportunity for some patient education, good opportunity for you to learn a little bit more about the drugs you're using and give you a little reassurance that, you're not going to put people down.
And even then, the Michael Jackson thing was propofol, and the dose that he took was enormous. So no, but it's accurate, and that's a thing, right? Where we see these things in popular media, so people get very worried about them. And I mean, we've both had patients who want to not get fentanyl for their fractured femur because they read that Matthew Broderick had an addiction problem,
or Tom Petty, or I'm going to stop breathing, and it's just no, you're not. It's okay.
Yeah, and it's like I'm not going to give you enough to cause any of those problems. But I do think it leads to an interesting conversation about how we give opioids now, right? Where there was a time where we were probably a little bit too opioid heavy, and I'm talking I'm talking 80s, 90s, and then we moved into being a little bit too judicious, right? Because now we're always worried about what opiates are going to come our way and how we treat them, and that led us to be kind of very puritanical in how we give them. And I definitely think that because we've all heard there's I'm not going to give him fentanyl. You don't deserve fentanyl.
Or the quote unquote drug seeking behavior.
And that's not to deny that those patients exist. Of course they do. But
they're
it's
rare.
not. They are. And it's not the diaspora that we've always kind of thought. We're like, well, if I give fentanyl, they're going to be addicted to fentanyl forever. Because it's also not a thought process that we apply to the 80-year-old who's having an MI. And we give them 50 mics of fentanyl to reduce the pain, or we give them, whatever, 1-for-1 of ketamine or a 0.5 milligram per kilogram of ketamine to settle them down. We don't consider those addiction problems, right? Because that patient has chest pain. They deserve it. And again, here you've got 40% with abdominal pain. And I feel like if you went to most medics and told them that not only is abdominal pain something that we should treat, but it's something we should treat with an opiate, I feel like a lot of medics would probably disagree with it.
You might get some pushback.
A couple, little pushback, a little bit. But here I think we actually see that not only do these medications work and they work well, it's something that we can feel a little bit more free to give as we have these patients who have pain. So it might be that, we have this kind of worry, what's going to happen with the pain, what's going to happen with the patient. Maybe this leads you a little bit more toward giving something like fentanyl where, 50 mics, 100 mics, it's not actually going to change their social outcomes so much that we may have been worried about previously. But this is a really interesting study. And again, this is Irizarry et al. This is coming out of the Bronx. There's a part of me that wants to call it the J-Lo paper, but since no one in here is named Jennifer Lopez, I can't really do that. I'm going to call it the Irizarry paper. But these guys did some really good work. It's really interesting information. Check out the paper. The link is below in our show notes. Be sure you subscribe when you hit that button down there. And for the Monday Afternoon Journal Club, I'm Ed Bowder. That's Dan Schwester. Follow us on all the other things, and we'll see you.